Nick Majerison here, thanks for downloading Top Med Talk. Welcome to EBPOM USA Part 2, a Perioperative Practicum with Professor Monty Mythen. This is taken from the second presentation, originally streamed live on topmedtalk.com, from the hugely successful EBPOM USA Masters Course, a Perioperative Care Practicum. Hear the full presentation from our Editor-in-Chief, Professor Monty Mythen, Chair at University College London and National Lead for Enhanced Recovery in the UK.
Second speaker you've already heard from, Professor Monty Mythen, the Chair at University College London, National Lead for Enhanced Recovery in the UK and a pretty much lifelong protagonist for the area. So Monty, look forward to your talk.
Thank you, Mike. So great pleasure to be giving this talk. The template here is from the Royal College of Anaesthetists in the United Kingdom. Both myself and Mike are College Council members there. This is the lead body in the UK responsible for training and standards in particular. And up until relatively recently, I've been the lead for the perioperative medicine programme. That's now been handed over to Professor Mike Grocott. Some potential conflicts of interest. I don't think any of them are particularly relevant to this talk, apart from two further down the list. My role on the College of Anaesthetists in the UK, and the work I did for our Department of Health that I allude to very transiently in passing. Now, for those of you who don't know the United Kingdom very well, it's a small group of islands along with the Republic of Ireland that's between Europe and the United States of America. So it's off the coast of America, effectively, if that's the way you want to look at it. And the landmass of England is about the same size as North Carolina. But in there, we've got 1/6 of the population of the United States of America, and we're about the 5th, if possibly the 6th largest economy in the world. Along with all of that and having a queen, which a lot of people have heard of, and we think she's pretty cool, we have this thing called the National Health Service that we're very, very proud of. So 85% of our healthcare is delivered free at point of use in a single payer system, and that's where most of us work. Give you some context. I was very lucky to be invited to give the plenary lecture at the European Society of Anaesthesia last year. I've not put this up to say, aren't I cool, I was asked to give the plenary lecture. It's interesting how long it took for the European Society to embrace perioperative medicine. It came last year as being a highlight, and only the year before, the Chinese Society of Anaesthesia, attended by more than 10,000 people, was titled sort of transition from anesthesiology to perioperative medicine. So the world is changing rapidly in this space. But I really put this up to highlight the fact that the lecture is an eponymous lecture, and it's named after Sir Robert McIntosh, which I'll go back to in a moment. Now, Sir Robert McIntosh is very well known to many people as being the first professor of anaesthesia outside of the United States of America. But also you probably know the Macintosh blade. So the curved laryngoscope blade is the Macintosh blade. It's based on a Boyle-Davis gag. So during a tonsillectomy, Robert McIntosh looked over the shoulder of the surgeon doing a tonsillectomy, and with this curved support gag in the mouth, he had a fantastic view of the target zone. And he developed a laryngoscope with a curved blade rather than a straight blade. Now, around the time he was doing that, as one of the first professors in the world, the big obsession for anaesthesia providers was maintaining an airway and keeping somebody asleep and alive. That was the big aim to that stage, the development of tubes, of airways, of novel drugs, of syringes, of lines, etc., to enable those things. But as early as 1949, Sir Robert McIntosh said there should be no deaths due to anaesthesia. And if you read on about what he had to say related to this statement, he said we've now really got to move on from this obsession with the airway and keeping people asleep and alive to the fact that when we do that in very many patients, they still die as a result of the quality of their perioperative care and or how they've been prepared for surgery. And he said that in 1949. And he formed within the Association of Anaesthetists a group to say we have to move on to start to look at the whole picture of patient care, such that nobody should die due to anaesthesia, and really nobody should die during elective surgery. Now, I said at the beginning in my opening statements that evidence-based perioperative medicine was formed to put on educational meetings and to bring people together to share ideas 20 years ago, the Royal College of Anaesthetists in the UK made its transition from saying, I think we understand what anaesthesia providers do, to embracing perioperative medicine on the 23rd of January 2015. So that's a fairly typical incubation period for new ideas. And as I said earlier, I get the impression that there's an inflection point around the world that everyone is now embracing this transition from the provision of anaesthesia to the broad care of patients under the guise of perioperative medicine. So here's our document from the College of Anaesthetists, released January 23rd, 2015. You can find it on our website. The document is called Perioperative Medicine, the Pathway to Better Surgical Care. It's accompanied by a short animation that runs for about 5 minutes, which has been watched all around the world, we believe now millions of times, which is a sort of sliding door experience of a patient who has a traditional care model, as described by Sol, where his problems are itemised but not necessarily treated. He has a bit of a wobble. He ends up on ICU reactively, develops some acute kidney injury, which becomes chronic kidney injury. The second time we replay the story, he goes through a perioperative pathway similar to that described, the POET experience. And he's tuned up and tweaked up at every angle. He's proactively put on intensive care. He doesn't develop those problems and he goes home and everything's fine and dandy, as we hope it should be. Now, importantly, on the left-hand side, the document we wrote collectively and published is a description of what we believe is in the patient's best interest. It's not the answer to how we get to that place. There's a lot of unanswered issues here, which I'll come back to. This is a picture of our president, sadly died relatively recently, J.P. Van Bassau, our immediate past president of the Royal College of Anaesthetists, who very much drove this agenda. He harnessed the energy of those who were interested in it and went public to make a commitment that the Royal College of Anaesthetists is committed to developing a collaborative programme for the delivery of perioperative care across the UK to deliver more efficient healthcare to improve patient outcomes and quality of life. Now, in the build-up to that, that was really quite controversial because there was quite a lot of anaesthetists, physicians in the Royal College of Anaesthetists, in a broad group, who were quite resistant to the idea that we would get away from our traditional duties and responsibilities. In other words, we've been trained primarily for the provision of anaesthesia. We already regard ourselves as perioperative physicians, etc. Why was the time right to consider that transition? Well, you've heard about a lot of this from the first speaker, from Sol Aronson. This is our UK numbers that relate to the challenges we have perioperatively. So in the year before we published that document, we believe of our budget at the time of about 100 billion UK pounds in England, spelt by the National Health Service on healthcare, 16 billion of that was spent on elective surgical care. So that's 16% of the budget. 10 million people had a surgical procedure. Now, I told you our population's 60 million. So even in a little country like ours that doesn't actually spend that much money on healthcare compared to the USA, 1 in 6 people had a surgical procedure. 25% of the population have the long-term conditions that Sol was referring to. Great news, the baby boomers coming through, that the population's getting older. We still have a challenge in the delivery of post-operative critical care in our country. So there's only a 1 in 5 chance, if you have major non-cardiac surgery, that you'll be able to get into a critical care environment. We know who the high-risk patients are, so for all the reasons that have been articulated already, they're relatively easy to spot. They're the patients who are older with multiple comorbidities. Now, they make up a minority of the patients. They make up about 20%. But 4 out of 5 of the deaths occur within that 20%. So it's not hard to start to work out where you need to focus your energies and your efforts. The final thing is, currently, even though around the world we're repeatedly reporting that there are long-term harms associated with what superficially appears to be successful surgery, i.e. the joint has been fixed, the tumour's gone, but the patient's had a silent heart attack or now has long-term kidney injury, Many of our systems have no way of tracking that. So we don't actually completely understand the consequences of our actions. Now in the UK, in the build-up to embracing perioperative medicine as a transition, we'd had pretty good success with our National Enhanced Recovery Programme. So in 2009, the government made a decision to rapidly spread enhanced surgical recovery, which you'll get the details of that. I know you all know about this already in the next session. It will concentrate on ERS. But our experience was that over a relatively short period of time, we tried to roll enhanced recovery out through major colorectal, major cancer gynae, major cancer urology, and the major joint replacements in the whole of the country of England. And the aim was to do it in 2 years and to kickstart it in 6 months. It took a little bit longer, but basically by 2012, we demonstrated increased productivity, increased quality, increased patient satisfaction, reduced cost, and almost complete implementation of enhanced recovery principles in every hospital in our country. It's one of the advantages of the type of system that we have. Now, it's a longer story as to what was required to kick that into action, but it was great to see that success. Now, a key part of that success came the recognition that it's a team game. So historically, surgery in the United Kingdom had been quite appropriately surgeon-led, but also not necessarily a team game. So it was based on the surgeon's name above the bed and individual order sets that were more about, although well-intended, they were more about the surgeon's preferences than consistent delivery of care and the patient's needs. And in the Enhanced Recovery Programme, the whole thing flipped around to put the patient at the centre of everything we did and to have patient and surgery-specific pathways that were independent of surgeon preferences, and to create a team that would deliver those pathways successfully. And here's a picture that was often shown at the time. It's the British cycling team in the Olympics, and in the Olympics in 2012, for this particular type of cycling where you ride round and round in circles inside, which works well in countries where it rains a lot, like ours, they won almost all of the medals. And the coach associated with that, Dave Brailsford, is known for the theory of marginal gains. So the theory of marginal gains is you get the team and you say to them every morning when you wake up, I want you to try and make 20 things 1% better to try and achieve a 20% gain. But what I don't want you to do in the morning is I don't want one of you to wake up and try and do one thing 20% better, because you will wreck the team. And you'll never make things 20% better by independently changing one thing. So I want you to work as a team continuously to see if you can make every little thing a little bit better. So this is the science they apply to it. The other reason we use this picture is when in building our Enhanced Recovery Programme, we said, when you come to meetings like this of rooms about this size to discuss how we're going to change things rapidly, you have to bring the whole team. You have to bring the surgeon, who's got to want it to happen. You have to bring the anaesthesia lead, because they're going to help it to happen. You've got to bring the nurse lead, because they'll be doing all the work in reality. And then you have to bring the administrative lead, who's going to cut the checks, because they'll ultimately become the problem if they're not part of the team. Now, the bigger team is much bigger than that, but that was part of it. The plus side for us as team anaesthesia is I was appointed as a national lead along with the surgeon. We demonstrated, along with our nursing colleagues, etc., how successful we were at delivering these continuous pathways. So we went from sort of who's team anaesthesia to, oh, you're these people who looks after this whole perioperative pathway that makes things a whole load better. You're really kind of good at this, good at communicating and working with everybody and making things happen. Again, along with our nursing colleagues are all talented in that way as well. It really shone a bright light upon us to say you can do this. So by April 2012, the 30th of April 2012, enhanced recovery had become a standard of care, and in public this declaration was signed that said, we believe enhanced recovery should now be standard practice. Now the signatures on this include healthcare leaders from all different areas. So College of Surgeons signing next to College of Anaesthetists and so on and so forth. So there's our Enhanced Recovery Programme launched January 23rd, 2015, 3 years after the Enhanced Recovery Partnership Programme had completed its main endeavour. And credit to Mike Grocott for this, he's sort of referring to it as, this is enhanced recovery on steroids. Everything that you talk about in the closer to the immediate procedure about enhanced recovery, the first thing it starts with is patient education and preparation. We've shown we can do enhanced recovery and do it really well, which is what happened at Duke. You will hear all about that in other people's programs. This is now just saying, okay, some of us have got up from the stool and we've gone out to look around us as what's happening before and after surgery, and we can make a much bigger difference by trying to fix this issue from the moment of contemplation to full recovery. So here's the definition of perioperative medicine that we've worked with. Describes the practice of patient-centred, multidisciplinary and integrated medical care of patients from the moment of contemplation of surgery until full recovery. It goes on to say that it improves short-term safety and long-term effectiveness of surgical treatments by the delivery of multidisciplinary, integrated medical care before, during and after surgery. We've had a lot of discussion about this in the last few days. When we use the word medicine, as in perioperative medicine, we don't mean physicians. We think holistically of integrated medical care as being medicine that all clinicians deliver in the broadest sense. But sometimes people turn around and read that as physicians. It's not. We're all in this together. That is the intercollegiate view. So our various different colleges, as we describe it in the United Kingdom, College of Surgeons, College of Nursing, College of General Practitioners, who represent all the different subspecialities, the physiotherapists, all had conversations about this, and they're agreeing that we are completely all in this together. It's a team game, and we're only going to be able to cope with the baby boomers coming through and deliver this cost effectively if we're all prepared to muck in to do the bits that we're best at. So what next from our perspective? Well, the first thing we decided to do, don't worry, this is small print here, the point is that we've embedded perioperative medicine into our anaesthesia curriculum. So we've defined what we believe constitutes training in perioperative medicine for somebody who's trained as an anaesthetist in the United Kingdom. And that transition was approved officially by our General Medical Council, which means it becomes an official training programme on the 26th of June, in June 2016. So now, after that, if you start your training and you get your fellowship of the Royal College of Anaesthetists, you are uniquely trained as a perioperative physician in the United Kingdom. Now, other subspecialities who choose to do this need to match that training curriculum to work in that space. And we want as many people as possible to do that, because we definitely are not capable of and can't do all of this work. That's crystal clear. What we want to define is what the work looks like and what's sufficient training to do that work. One of the next things we did was to appoint 2 national clinical leads. So this is Mike Swart, Chris Snowden, geographically from 2 different ends of our country, deep in the southwest and up in the northeast. Very well known as being active in the perioperative space. But what was important here is these appointments were made co-funded by our Royal College of Anaesthetists and the government. So when they were appointed, both people put money on the table and said, we need some leaders with time to effect change. We also then appointed a local lead in every hospital in the country. We invited every hospital in the country to put forward a name of somebody who would be their local perioperative medicine lead. So whoever was in for being the primary conduit and communicator of how we were making this transition from our current position to the new position, somebody put their hand up, they were identified, and they became the to and fro flow of information. They come in for information sharing, meetings, etc. Then we appointed a fellow. This is Anne-Marie, appointed as the first perioperative medicine fellow to run the programme. And then they came down and said, what do we think realistically are our top priorities for the first main year where we got going? So this is going to be refreshed now, because this was published in March 2017. There'll be a new list of priorities now. And not surprising, very many of them overlap with the principal content of this meeting. So it's unusual for anyone in the world to come up with different big ideas that need checking off quite quickly. So we've done the enhanced recovery thing, so we're in pretty good shape there. We then say, top of the list, anemia. You'll hear a lot about that. It's a big early win. Shared decision making, i.e. that very difficult thing about how to make the right decision not to do surgery. In all of our healthcare systems, that's a very challenging thing, because most of the revenue streams relate to doing the surgery, and if you spend a lot of money doing the surgery that makes somebody worse and produces a worse outcome that triples the cost of their care, that's not smart healthcare. The really hard thing to do is how to work out not to do the surgery. Develop the perioperative teams, because we can deliver these patients looking fantastic in the PACU, and it can all go horribly wrong in the next 24 hours. So we have to have zero tolerance of anything going wrong once you've got it right the first time. Collaborate with our primary care physicians. So most of our healthcare in the United Kingdom is delivered through what we call general practitioners. They are the principal deliverers and guardians of everyone's healthcare. We have to work how to integrate the acute healthcare system in our country with that primary healthcare system. We, the acute healthcare system, gets the majority of the money. They have to do the majority of the work. So we have to balance that somehow. We need to get better at predicting post-operative mortality and morbidity so we can properly inform patients, because we have this terrible tendency to quote what happens on average as a result of these procedures, not what you can expect for you as an individual. And the final one is probably the biggest item that is coming to all of us now, which is the recognition that there's a huge burgeoning growth, great in one way, of frail and elderly patients who are cognitively impaired. So that's, for many of us, that is new medicine. I know we always looked after patients like that, typically with things like fractured neck or femur, but now this is a population that is expecting to live on for, quite rightly, for decades, and they have new challenges that we need to learn how to care for them more effectively. Last couple of comments. In 2009, it was a very interesting time to be working in our National Health Service. We had the highest level of spending that we'd seen ever on healthcare. And it was a very exciting place to work, because very bravely at that time, in the face of a global financial crisis, the healthcare leaders had said, just focus on quality. If you get up every day and say it's all about the patient, stupid, then you will pursue quality. And if you pursue quality, it will deliver value, because high quality care is almost invariably, when done well, associated with lower cost. Get it right first time, and the patient stays well. By the time we'd gone through different changes, the financial squeezes had come back in, by 2017 we were back to what I've been hearing in reality for most of my clinical life, is of course it's all really about the patient, stupid, but it's really about the money, stupid. So unless you can show me that you're going to save me some money today, you've got to show me where the money is. So part of the program that we got into was trying to generate that data to determine the value of these perioperative care teams. So led by Dr. Ramani Munasinghe from the Royal College of Anaesthetists, started a perioperative quality improvement program where 70 hospitals, which is a significant cohort in our overall number of hospitals in the UK, started to collect data on just 5 patients per week to do snap audits effectively, but to generate large numbers of patients, so they could see what in their perioperative care pathway related to subsequent outcomes, and in particular health economic evaluations. So we will be able to inform the debate on these changes. The next thing I'd like to highlight is the education side of it. So my colleagues at UCL, led by David Walker, Abigail Whiteman and Phil Sherrod, launched a massive open online course. For those of you who are not familiar with MOOCs, these are what they say on the can. They're massive, they're open, they're online, and they are free at point of use. There are lots of them out there. We believe this is the first one for perioperative medicine, launched in July 2017. In the first course, about 5,000 people around the world signed up to do this course. And what's really important about that is it was a huge, broad sweep of different practitioners did it. Everyone who was interested in this space. Free, open, online. Next steps in closing. We still don't know what we're going to do about long-term follow-up. those people who have well-integrated electronic health record systems where they hang on to their patients, the Kaisers of this world, for example, can tell us more about that than I think our system can at the moment. We still don't know what we're going to do about the manpower. This is all a great idea, but in any document we've written, we haven't said, well, who's actually going to do this? We think one of the biggest wins is prevention, because if you stop those patients becoming unwell and all their wheels popping off, there's a lot less work to do in the acute healthcare environment. You spend a lot more time and energy doing it reactively. Leadership is absolutely key. That's why one of the reasons we're here today. Other physicians, I'm talking from the perspective of a physician anaesthesia provider from the Royal College of Anaesthetists, other physicians are probably much more important in this space with the baby boomers coming through. So our care of the elderly doctors who've embraced this and lead elderly care surgical programs, we'll hear more about later on, are having a huge impact. I think when you become frail and elderly, that's who you want leading your healthcare package. You want somebody who can go from home to ideally home again, who has a holistic view of your needs. And then what we refer to as physician extenders, in other words, the more we can dissipate the workload through the whole healthcare system, the more we can get people involved, the more rapidly we can get those people trained, the better it will be. Final little comment. Around the time that we launched the Perioperative Medicine programme, we surveyed over 5,000 members of the Royal College of Anaesthetists, and we asked them what they thought about the Perioperative Medicine programme. Now, 75% were supportive or very supportive. 9.6% were not very supportive, and they're starting to be convinced differently. The really important thing is only 3% were not at all supportive. But prior to gathering that data, that 3% was making 93% of the noise. So it's important to know the truth behind what people really think. They were standing on boxes, banging dustbin lids together, screaming that none of us want this. They've all gone very quiet, which I think is a good thing. We've still got to try and understand how we nudge it up to everyone being supportive of this. Just a note at the bottom that 12.5% of people didn't fully understand the question. So I'm sorry about that for behalf of the Royal College of Anaesthetists, but there we go. So I'll close there. I was asked to, in one lecture, to say, are we leading the way? I don't think the UK is leading the way. I think the world is changing with us, around us. We're all here today because we all believe this is the right thing to do. Thank you for listening.
If you liked the sound of that and think you and your practice would benefit from attending such a course, fear ye not. Don't worry, because all you need to do is go to the EBPOM website and check out EBPOM USA Chicago Masters Course, a Perioperative Care Practicum. Also, of course, you can meet the Top Med Talk team at any of the EBPOM events that we cover. Check out the website ebpom.org. Our next big event is EBPOM 2018, the London Perioperative Medicine Congress. That's at the Institute of Engineering and Technology between the 4th and the 6th of July. Check out the website for more details, ebpom.org.